3, 2, 1.
Baihaqi.
Sorry, start. Okay, hi, hello everyone. Okay, so today I have some interesting story to tell of you. Do you want to hear it? Can come closer. Okay, this story is about my first time being a clinical medical student. Let's go. Okay, let's go. Sorry. Excuse me. Can I know where's Dr. Naveen?
Oh, you Baihaqi dental
Yes.
right? He's looking for you, by the way.
Oh, okay, fine. Thank you. Hello, excuse me.
Hi.
Can I know where's Dr. Naveen?
Okay, Dr. Naveen is there. Come.
Oh,
show
okay.
you.
Thank you. Naveen, my name is Baihaqi.
Okay, hello. Sorry, there's no time for introduction. I think we have an emergency case now. We have to go over that. Okay. Hello, Mr. Leela. How are you? So, my name is Baihaqi Spine.
Here's the father.
Thank you. Sorry to say, Leela, but then we detected that your baby is having congenital anomaly, and it's a type of neural tube defect, and we are sorry to say that. Hello, sorry just now I couldn't know about it. So can you introduce yourself?
My name is Baihaqi from Clinical.
Oh, year 3. Welcome to clinical years. So just now at Baihaqi, we encountered a case of congenital anomaly where the patient's baby is having a neural tube defect. So do you have any idea about neural tube defect?
It's about congenital malformation.
Of course, it's a type of congenital malformation, but any information about that?
I forgot it.
It's okay, fine. This is your first clinical year, right? So you will learn about this. So for this, I think it's better if you meet our specialist, Dr. Agenesis. So we have to go and meet right now. Okay?
Sure.
Hello, doctor. Good morning. Good morning, doctor. So this is an emergency case that I have just now. So please have a look, doctor. Alright? And for information, this is our new clinical student.
Okay, good morning, Baihaqi. Right. So, what's the case of this patient?
So the case is the patient is having a baby which is born with a neural tube defect, and that's the case, doctor. And for him, I asked him to gain more knowledge about neural tube defect from you, doctor.
Alright, so Baihaqi, right? Alright. So, do you know what's neural tube defect?
No, sorry, I forgot.
So, neural tube defect is one of the abnormalities in the brain development that causes the formation of neural tube, which gives rise to the ventricular system as well as a brain and spinal cord. So, you're from MSU, right? I know you know the medical words. So, have this.
This was, I think maybe enriching picture, enriching life transforming picture.
Wow! Damn.
Let's look this. Here.
Hello everyone, I'm Leela here and I'm going to start off this video with the development of the central nervous system. I'm going to explain about the embryology and anatomy of the nervous system briefly. Let's start with neurulation. Neurulation is the process that initiates the development of the nervous system, which involves the formation of the neural tube, which eventually becomes the brain and the spinal cord. Neurulation is divided into two, which is primary and secondary. The primary neurulation takes place from day 18 to day 21, whereby the notochord, a rod-like structure, induces the overlying ectoderm to thicken and form the neural plate. What is the neural plate? Neural plate is a flat layer of cells which will fold to create the neural tube. The neural plate then starts to fold, forming the neural groove with neural folds on either sides. The neural folds then move towards each other and fuse to form the neural tube. This begins in the middle of the embryo and proceeds both cranially towards the head and caudally towards the tail. During the secondary neurulation process, the tail bud is formed. In the caudal region, a secondary process forms the lower part of the spinal cord. The tail bud cells condense to form a rod, which then cavitates to form the neural tube. The next process which will take place is the neural crest formation. The neural crest cells will arise from the edges of the neural folds and migrate to various parts of the embryo. They give rise to diverse cell types including the sensory and autonomic ganglia, Schwann cells and adrenal medulla cells. The next process which will take place is the differentiation and segmentation, where the primary brain vesicles and the secondary brain vesicles will be formed. During the 4th week, the cranial part of the neural tube forms 3 primary brain vesicles, which is the prosencephalon, mesencephalon, and rhombencephalon. During the 5th week, the prosencephalon divides into the telencephalon and diencephalon. The rhombencephalon divides into the mesencephalon and myelencephalon. Next, histogenesis and gliogenesis will take place. The neuroepithelial cells line the neural tube and give rise to neurons, astrocytes and oligodendrocytes. Neurogenesis is a process where neurons are generated. It involves the proliferation of neuroepithelial cells, followed by their differentiation into neurons. Gliogenesis is the formation of glial cells, including astrocytes and oligodendrocytes, which will support and insulate neurons. Next will be the formation of the major structures, which are the brain and the spinal cord. The telencephalon gives rise to the cerebral hemisphere, while the diencephalon forms structures such as the thalamus and the hypothalamus. The neural tube caudals to the brain vesicles develops into the spinal cord with specific regions differentiating into sensory and motor areas. And lastly, the peripheral nervous system is formed. Sensory ganglia, which is derived from neural crest cells, these ganglia contain the cell bodies of sensory neurons, and autonomic ganglia, which is also derived from neural crest cells, includes sympathetic and parasympathetic ganglia. Axons grow out from neurons in the spinal cord and brain to form the peripheral nerves, which connect the central nervous system to the rest of the body. So the key molecular signs and factors. Sonic hedgehog plays a critical role in the patterning of the neural tube. Bone morphogenetic proteins involved in the dorsal ventral patterning of the neural tube. And notch and Wnt signaling is important in cell differentiation and proliferation within the developing nervous system. Clinical relevance. Neural tube defects. Failures in neural tube closure can result in conditions such as Spina Bifida and Anencephaly. Genetic disorders whereby mutations in genes involved in neural development can lead to congenital neurological disorders. So that's all for me. I will pass to my next member to explain in detail about congenital malformations.
Hello and welcome to our video on classification of congenital malformation of nervous system. My name is Karina and today we will explore the various types of these congenital anomalies. Understanding this classification is essential for healthcare professionals to provide the best care for affected individuals. Let's dive in and learn more about this important topic, shall we? Alright, did you know congenital malformations of the nervous system are structural anomalies that occurs during the development of the central and peripheral nervous systems in utero? These malformations can result from genetic factors, environmental influences, or a combination of both. So, they are classified based on the affected part of the nervous system and the nature of the malformations. So, now we're going to start with the first one, which is the neural tube defects. One of the earliest steps in brain development is the formation of the neural tube, which gives rise to the ventricular system, brain, and spinal cord. Partial failure or reversal of neural tube closure may lead to several malformations, each characterized by abnormalities involving neural tissues, meninges, and overlying bones or soft tissues. Collectively, neural tube defects are the most frequent types of CNS malformation. Folate deficiency during the first trimester sharply increases risk through uncertain mechanisms and represents an important opportunity for prevention, as administration of folate to women of childbearing age reduces the incidence of neural tube defects by up to 70%. The combination of imaging studies and maternal screening for elevated A-fetoprotein has increased the early detection of neural tube defects. The most common defects involve the posterior end of the neural tube, from which the spinal cord forms. These can range from asymptomatic bony defects, spina bifida occulta, to spina bifida, a severe malformation consisting of a flat, disorganized segment of spinal cord associated with an overlying meningeal outpouching. Myelomeningocele is an extension of CNS tissue through a defect in the vertebral column that occurs most commonly in the lumbosacral region. Patients have motor and sensory deficits in the lower extremities and problems with bowel and bladder control. The clinical problems derive from the abnormal spinal cord segment and often are compounded by infections extending from the thin or ulcerated overlying skin. Anencephaly is a malformation of the anterior end of the neural tube that leads to the absence of the forebrain and the top of the skull. Varying amounts of posterior fossa structures may be present. An encephalocele is a diverticulum of malformed CNS tissue extending to a defect in the cranium. It most often involves the occipital region or the posterior fossa. When it occurs anteriorly, brain tissue may extend into the sinuses. Okay, so now we're gonna go ahead and talk about 4 brain malformations. We start off with microencephaly, describes the group of malformations in which the volume of the brain is too small. Usually, it is associated with a small head as well, microcephaly. It has a wide range of associations, including chromosome abnormalities, fetal alcohol syndrome, and human immunodeficiency virus (HIV) and Zika virus infection acquired in utero. The unifying features is decreased generation of neurons destined for the cerebral cortex. During the early stages of brain development, as progenitor cells proliferate in the subepidermal ventricular zone, the balance between cells leaving the progenitor population to form the cortex and those remaining in the proliferating pools affect the overall numbers of neurons and glial cells generated. If too many cells leave the progenitor pool prematurely, there is inadequate generation of mature neurons, leading to a small brain. Next, we have megaencephaly, as excessive brain volume that is always associated with a large head, is far less common and mostly associated with rare genetic disorders. Disruption of neuronal migration and differentiation during development can lead to abnormalities of gyration and new cortical architecture, often taking the form of neurons ending up in the wrong location. Mutations in various genes that control migration result in a variety of malformations. A representative example of Holoprosencephaly, characterized by disruption of normal midline patterning. Mild forms shows absence of the olfactory bulbs and related structures. Agenesis. In severe forms, the brain is not divided into hemisphere or lobes, and they may be facial midline defects such as cyclopia. The best known genetic causes involve acquired or inherited loss of function mutations in components of the Hedgehog signaling pathway. Other examples include loss of gyri, which may be complete Lissencephaly, or partial and increased number of irregularly formed gyri, Polymicrogyria. So now, we're going to move to posterior fossa anomalies. The most common malformations in this region of brain result in the misplacement or absence of portions in the cerebellum. Chiari malformation, which is the Chiari type 2 malformations, combines a small posterior fossa with a misshapen midline cerebellum and downward extension to the vermis through the foramen magnum. Hydrocephalus and a lumbar myelomeningocele typically are also present. A far milder Chiari type 1 malformation has low-lying cerebellar tonsil that extends through the foramen magnum. Excess tissue in the foramen magnum results in partial obstruction of CSF flow and compression of the medulla, with symptoms of headache or cranial nerve deficits, often manifesting only in adult life. Surgical intervention can alleviate the symptoms. Dandy-Walker malformation is characterized by an enlarged posterior fossa, absence of cerebellar vermis, and a large midline cyst. Okay everyone, the last classification is perinatal brain injury. Brain injury occurring in the perinatal period is an important cause of childhood neurologic disability. Cerebral palsy is a term for non-progressive neurologic motor deficits characterized by spasticity, dystonia, ataxia, or atitosis, and paresis attributable to injury occurring during the prenatal, perinatal periods. Signs and symptoms may not be apparent at birth and only declare themselves later, well after the causal event. The two major types of injury that occurs in the perinatal period are hemorrhage and infarcts. This differs from the otherwise similar lesions in adults in terms of their locations and the tissue reactions they engender. In premature infants, there is an increased risk of intraparenchymal hemorrhage within the geminal matrix, most often adjacent to the anterior horn of the lateral ventricle. Hemorrhages may extend into the ventricular system and from there to the subarachnoid space, sometimes causing hydrocephalus. Infarcts may occur in the supratentorial periventricular white matter, which is periventricular leukomalacia, especially in premature infants. The residua of these infarcts are chalky yellow plaques consisting of discrete regions of white matter necrosis and dystrophic calcifications. When severe enough to involve the grey matter and white matter, large cystic lesions can develop throughout the hemisphere, a condition termed multicystic encephalopathy. Last but not least, certain infections which may be acquired transplacentally or during birth have a propensity to cause destruction brain lesions. Agents in this group, commonly referred as TORCH, include toxoplasmosis and CMV, which can both result in parenchymal calcifications along with the tissue injury. Well, I guess this is the end of this video. If you would like to learn more about the details on congenital malformation of the nervous system, do check out other videos in our channel. Bye!
Hi! I know you clicked this video because you want to know about forebrain anomalies, right? So, you come to the right place. So today, I'll be explaining on Megalencephaly, Microencephaly, and Lissencephaly. So without further ado, let's go! This is Katie. Her mom found out when she was 6 months pregnant with her that she is going to have megalencephaly. So, what is megalencephaly? Megalencephaly, also called microencephaly, is a condition in which an infant or child has an abnormally large, heavy, and usually malfunctioning brain. So it is defined as an increased growth of cerebral structures related to dysfunctional anomalies during the various steps of brain development in the neuronal proliferation and or migration phases, or as a consequence of postnatal abnormal events. Normally, neuron proliferation, the process in which nerve cells divide to form new generation of cells, is regulated so that the correct number of cells is produced in the proper place at the appropriate time. In a megalencephalic brain, too many cells are produced either during development or progressively as part of another disorder, such as one of the neurofibromatosis or leukodystrophies that eventually lead to megalencephaly. So people with megalencephaly present with a head circumference measurement 2 standard deviation above the age-related mean. It affects males more than females, and mind you that megalencephaly is different from microcephaly, which is called megacephaly or megalocephaly, which describe a big head and which doesn't necessarily involve or indicates abnormality. So, megalencephaly is classically defined into 3 groups according to their etiology, which are idiopathic or benign, metabolic, and anatomic. So, benign or idiopathic megalencephaly refer to children who have an abnormally large head without neurological impairment. Metabolic megalencephaly associated with metabolic disorders that lead to abnormal accumulation of substances within the brain. So these substances can include lipids, glycogen, or other metabolic byproducts. For example, Tay-Sachs disease, a genetic disorder leading to the accumulation of GM2 ganglioside in neurons. Canavan disease, a genetic disorder that disrupts the normal breakdown of N-acetyl aspartic acid, leading to its accumulation and subsequent brain swelling. So the symptoms can include developmental delays, seizures, motor dysfunction, and progressive neurological decline. Anatomic megalencephaly is characterized by an inherent structural enlargement of the brain, often without an associated metabolic disorders. The brain is larger than normal due to hyperplasia or hypertrophy. It's often associated with genetic mutation affected brain growth and development. For example, mutation in genes involved in cell growth regulation can lead to overgrowth syndrome. For example, Soto syndrome, a genetic disorder characterized by overgrowth during childhood, distinctive facial features, and learning disabilities, often linked to mutation in the NSD1 gene. So the symptom, this can vary widely but might include cognitive impairments, motor difficulties, and sometimes epilepsy. Some individuals may be asymptomatic aside from having a larger head size. So for the treatment, there is no standard treatment for megalencephaly. Treatment will depend upon the disorder in which the megalencephaly is associated with and will address individual symptoms and disabilities. So next, for brain anomalies that you need to know is microencephaly. So microencephaly describes the group of malformation in which the volume of the brain is too small. Usually it is associated with a small head as well, or we call it as microcephaly. So the causes of microcephaly in most babies are unknown. So some known cases of microcephaly include infection during pregnancy such as Zika, toxoplasmosis or cytomegalovirus, malnutrition during pregnancy, malnutrition in the baby after birth, exposure to harmful substances such as alcohol or certain drugs, and also problem with blood supply to the baby's brain during development. Microcephaly has a wide range of association, including chromosome abnormalities, fetal alcohol syndrome, and human immunodeficiency virus (HIV) and Zika virus infection acquired in utero. The unifying feature is decreased generation of neurons destined for the cerebral cortex during the early stages of brain development as progenitor cells proliferate in the epididymal ventricular zone. The balance between cells leaving the progenitor population to form the cortex and those remaining in the proliferating pool affect the overall numbers of neurons and glial cells generated. If too many cells leave the progenitor pool prematurely, there is inadequate generation of mature neurons leading to a small brain. Microcephaly can be diagnosed during pregnancy through ultrasound or after the baby is born. Prenatal diagnosis of microcephaly can be done late in the second or early in the third trimester. To diagnose microcephaly after birth, a healthcare provider will measure the head circumference of the baby. Seizure, developmental delay such as problems with speech and walking, intellectual disability, problems with movement and balance, feeding problems such as difficulty swallowing, hearing loss, and vision problems. So there is no known cure or standard treatment for microcephaly. So microcephaly can range from mild to severe, and treatment options can range as well. Lissencephaly includes a range of severe brain malformation, including agyria, absent gyri, pachygyria, broad gyri, and subcortical band heterotopia. In Lissencephaly, which literally means smooth brain, the surface of the brain appears smooth. It may occur as an isolated Lissencephaly or in association with certain syndromes such as Miller-Dieker syndrome. Lissencephaly is caused by a defect in neuronal migration during embryonic development between 12 and 24 weeks of gestation that result in the absence of normal development of brain, gyri, and sulci. Children with Lissencephaly present with significant developmental delays and mental disability, but these vary from child to child depending on the degree of brain malformation and intractable epilepsy. Lissencephaly can be caused by non-genetic and genetic factors. Non-genetic factors include viral infection of the mother or the fetus, especially during the first trimester, and insufficient supply of oxygenated blood to the brain during fetal development. There are several genetic causes also, such as LIS1, PAFAH1B1, DCX, ARX, RELN, and other genes. Cytomegalovirus (CMV) has been associated with developing lissencephaly by reducing blood supply to the fetal brain. The severity of CMV infection depends on the gestational age. Early infection is more likely to cause lissencephaly because neuronal migration takes place early in the pregnancy. Symptoms may include seizure, feeding difficulty, muscle spasm, mental disability, severe psychomotor impairment, failure to thrive, developmental delays, and sometimes hand, fingers, or toe anomalies. However, some children may develop normally with a mild learning disability. Management for children with lissencephaly is symptomatic and supportive. Treatment aims to improve the intake of nutrient in patients with feeding difficulties and the use of anticonvulsant drug to prevent or control seizures. I think that's all from me. Don't forget to like and subscribe. Bye.
Hi, I am Aimi. So I'll be talking about the Holoprosencephaly. So Holoprosencephaly is actually a rare and complex congenital brain disorder that occurs due to anomalous signaling interactions between the neurocrest and neural octodem and significantly impacts the development of the human brain. So this condition is characterized by an incomplete separation of the cerebral hemispheres, resulting in a single, a fused forebrain structure during fetal development. Holoprosencephaly, which is we call also as HPE, leads to a wide spectrum of neurological and physical abnormalities, with its severity varying from mild facial features abnormalities to severe cognitive and physical impairments. So we have few types of HPE. The first one is allobar, which is the most severe form that is characterized by a complete failure to partition for the forebrain into left and right hemispheres, results in a single centrally located ventricles. Next, we have the semilobar, which is a partial forebrain cleavage. And we have the lobar, almost complete forebrain cleavage. As you can see here in the picture, we have the lobar, semilobar, and a lobar defect, which are the malformation of the brain. So for causes, extensively researched cases of HPE primarily focus on individuals with normal karyotypes but with chromosomal anomalies, and these cases seldom coincide with malformation syndromes. In a majority of live birth affected by HPE, the condition is classified as non-syndromic and non-chromosomal, indicating that it cannot be ascribed to chromosomal or syndromic origins. This category encompasses environmental causes, deletions or gene mutations that play a role in HPE or unidentified factors. So the etiology of HPE can be divided into the following categories. The first is genetic causes and non-genetic causes. Okay, so for genetic causes, it has the non-syndromic monogenic causes, which SHH anomalies are the most common defects recorded in HPE patients with associated midline defects. Other leading genetic causes include ZIC2, SIX3, and TGIF. Next is syndromic causes. Approximately 32% to 42% of the cases occur due to anomalies of chromosome number, most commonly trisomy 13, followed by trisomy 18 and triploidy. Next, we have the specific syndromes also under genetic causes related to HPE include both autosomal dominant and autosomal recessive syndromes, including the following. The first one is autosomal dominant, which is the first one is CDON gene related to the Stanfield syndrome. Next, we have the FGFR1 gene related Kalman syndrome 2 and Hounsfield syndrome. Next, we have the autosomal recessive, consists of the DHCR7 gene related Smith-Lemli-Opitz syndrome. Next, we have the HHAT encoding HHOP acyltransferase. Next, we have the PLCH1 encoding phospholipase CETA1. Next, we have the STIL encoding a factor required for maintenance for the primary cilia. And last but not least, we have the CENPF gene-related Strom syndrome. So next, for the variants in genes, we have the driver gene. So it is essential to the phenotype of the patient carrying a variant SHH, ZIC2, SIX3, FGF8, and FGFR1. Next, we have the silent modifier gene, VOC. And last but not least, we have the predisposing genes, all other genes responsible. So HPE exhibit associations with various maternal factors. Pre-gestational maternal diabetes is one such factor. Additionally, maintaining consistent maternal folic acid supplementations appears to offer protective benefits. Studies in animals have provided insights into potential teratogenic influences leading to HPE, including exposure to substances like ethanol, salicylate, retinoic acid, mycotoxins such as ochratoxins, Hedgehog signaling inhibitors like cyclopamine, and drugs that disrupt cholesterol biosynthesis. Furthermore, the environmental factors, including polycyclic aromatic hydrocarbons from sources like cigarette smoke and charred meat, 9-tetrahydrocannabinol, THC found in cannabis, and piperonal butoxide, PBO, a pesticide synergist frequently detected in indoor dust, also warrant consideration in understanding HPE's etiology. So as we can see on the right side, on the right picture, we have the picture label A is the infant with allobar, HPE, and cyclopia, and also the proboscis above the single eye. So you can see the single eye detected. And then we have the photo B, the second one is the infant with allobar HPE and Sebocephaly and closely spaced eyes. Next, we have the photo C, which is the infant with semilobar HPE and microcephaly, cleft lip and cleft palate. And photo D, we have the child with the semilobar HPE and closely spaced eyes and mid-face retraction. Next, we'll be talking about the symptoms of the general HPE. First, we have the developmental delay, and then we have the intellectual disability, epilepsy, and seizures, small head microcephaly, large head microcephaly. We have the associated fluid in their brain, hydrocephalus, facial abnormalities, tooth abnormalities, single central incisor, and we have the cleft lip or palate, and then we have the pituitary gland, problems regulating body temperature, heart rate, and breathing, and last but not least, we have the feeding difficulties. So we have the symptoms according to the types that we have. So the first one, which is the allobar HPE, we have the single eye cyclopia, very closely spaced eye, and also maybe like missing eyes. Next, we have these very small eyeballs, microphthalmia with a tubular-shaped nose proboscis. Next, we have the closely spaced eyes, orbital hypothyroidism with a flattened nose or cleft lip that occurs in the middle of their lip, medium cleft lip, or on both sides, which is the bilateral cleft lip. So next, we have the signs and symptoms for the semilobar HPE. We have the closely spaced eyes, very small eyeballs, or one or no eyes. Next, we have the flattened bridge and tip of their nose, one nostril, median cleft lip, or bilateral cleft lip. And last but not least, we have the cleft palate. Next, we have the lobar HPE. We have the bilateral cleft lip, and then we have the closely spaced eyes, and then depressed nose and HPE. In these types can be very in symptoms, but each of the syndromes have its own characteristics and symptoms. And yeah, we also have the general symptoms and also the specific symptoms for each types. Next is the diagnosis. So healthcare providers can often identify HPE, especially more severe cases before your baby is born, through a prenatal ultrasound. So they may need to do the MRI too. And then, although healthcare providers can identify HPE with prenatal imaging, they most frequently diagnose HPE after your baby is born when facial abnormalities or neurologic issues are present. They then perform head imaging test to confirm the diagnosis. Infants with very mild forms of HPE may not be diagnosed until they are about 1 year old. In this case, developmental delays often signal a problem in the neurological issue, so which then prompt healthcare providers to order brain imaging tests. So, tests to diagnose this HPE. First, we have the head ultrasound, which ultrasound is actually a non-invasive diagnostic imaging test. It is a high-frequency sound wave to create a real-time picture or video. So, next is the magnetic resonance imaging (MRI), which is a brain scan. It is used to show the very clear images of the structure and tissues in your child's brain. Next, we have the head computed tomography CT scan. CT scan will produce the 3D images of the body part being scanned. In this case, your child's head and brain. So, healthcare providers use DNA studies such as the chromosomal analysis and cytogenetic molecular testing to determine the exact cause of HPE if possible. If genetic testing reveals any kind of chromosomal or genetic issue that's associated with the Holoprosencephaly, your healthcare provider will recommend genetic counseling if you are considering having another biological child. So last but not least, we have the treatments for this HPE case, the last part of this HPE case. So the management of patients with HPE is symptomatic and requires a multidisciplinary approach. It targets each organ system and related complications. Epilepsy is a common complication in patients with HPE. A single seizure occurs in approximately 50% of all HPE children, some of whom may require multi-drug anti-epileptic therapy. When HPE is associated with the microcephaly, coexisting hydrocephalus is typically present. This should be immediately treated with shunt surgery while preventing overdrainage of CSF. Motor anomalies, when present, warrant treatment. Spasticity and dystonia require pharmacological interventions, including intrathecal baclofen pumps and oral trihexyphenidyl and physical and also occupational therapy. Orofacial motor dysfunction is compounded by the structural anomalies like cleft palate or lip, causing aspiration, further progressing to pneumonia, causing a serious feeding challenge. This can require structural surgical correction. The hormone dysregulation caused by the absence of well-formed hypothalamus can manifest as a pituitary hormone deficiencies, most commonly diabetes insipidus. This manifestation of other hormonal deficits is rare. However, prednisone, tyrosine, and growth hormone supplements may be required in patients with other deficiency symptoms. Poor nerve migration to the GI tract causes poor gastric and colonic motility and also gastroesophageal reflux. This can be managed by placing a gastrostomy tube in severe facial defects. Medications and anti-reflux procedures in patients with isolated severe GERD are indicated in other cases. So I think that's all for the HPE cases. So we'll talk about more topics in the future in the next video. Thank you. Bye. Hi, I'm Aimi. So I'll be discussing about Polymicrogyria in this video. So let's increase your knowledge by watching and listening to this video. So the definition of this PMG, polymicrogyria, is a condition characterized by the abnormal development of the brain before birth. The surface of the brain normally has many regions of folds called gyri. In people with PMG, the brain develops too many folds and the folds are unusually small. The name of this condition literally means too many poly, small micro, folds gyria in the surface of the brain. PMG can affect part of the brain or the whole brain. When the condition affects one side of the brain, researchers describe it as unilateral. When it affects both sides of the brain, it is described as bilateral. The signs and symptoms associated with the PMG depend on how much of the brain and which particular brain regions are affected. Researchers have identified multiple forms of PMG. The middle form is known as unilateral focal PMG. This form of the condition affects a relatively small area on one side of the brain. It may cause minor neurological problems such as the mild seizures that can be easily controlled with medication. Some people with unilateral focal polymicrogyria do not have any problems associated with the condition. Bilateral forms of PMG tend to cause more severe neurological problems. This condition causes severe intellectual disability, problems with movement, and seizures that are difficult or impossible to control with medication. PMG most often occurs as an isolated feature, although it can occur with other brain abnormalities. It is also a feature of several genetic syndromes characterized by intellectual disability and multiple birth defects. These include 22q11.2 deletion syndrome, Adams-Oliver syndrome, Aicardi syndrome, Galloway-Mowat syndrome, Joubert syndrome, and Zellweger spectrum disorder. Next, let's talk about the causes of this polymicrogyria. So, in most people with polymicrogyria, the cause of the condition is still unknown. However, researchers have identified several environmental and genetic factors that can be responsible for this disorder. Environmental causes of polymicrogyria include certain infections during pregnancy and a lack of oxygen to the fetus, intrauterine ischemia. Researchers are investigating the genetic causes of polymicrogyria. The condition can result from deletions or rearrangement of genetic material from several different chromosomes. Additionally, mutations in one gene ADGRG1 have been found to cause a severe form of the condition called bilateral frontoparietal polymicrogyria. The ADGRG1 gene appears to be critical for the normal development of the outer layer of the brain. Researchers believe that many other genes are probably involved in the different forms of polymicrogyria. So for the top picture, the left side is the normal brain and the right side is polymicrogyria, and the picture below is the gross of this polymicrogyria. So for the presenting symptoms, they have few. The first one is actually the recurrent seizures, epilepsy. Next is delayed development. Next is crossed eyes. Then muscle weakness or paralysis. And then we have the problems with speech and also swallowing. Next is the diagnosis of this polymicrogyria PMG. So PMG is diagnosed by brain magnetic resonance imaging MRI, which will show the abnormal brain structure and provide information on the location and extent of the abnormality. In persons with seizures, an EEG can be helpful to confirm the seizure type. Persons with PMG should also be considered for genetic testing as a number of genes have been associated with this brain change. So we are coming to the last part of this polymicrogyria, which is the treatments. So PMG malformation cannot be reversed, but the symptoms may be treated in children and also adults. The first line treatment for persons with seizures is anti-seizure medications, and the medication chosen depends on the type of seizures or epilepsy syndrome. So I think that's all for this polymicrogyria. So we'll talk about more topics in the future in the next video. Thank you. Bye.
Hi everyone, I'm Benila here. So I'll be discussing about the two significant brain development disorders, which is the neuronal heterotopia and agenesis of corpus callosum. These conditions affect the brain structure and function that leads to a variety of clinical symptoms and challenges. So let's start with the neuronal heterotopia. This condition is a neuronal migration disorder where normal cortical neurons are abnormally located in different areas. This occurs due to disruptions in the neuronal migration process during brain development, where neurons move from their place of origin in the germinal zones to their final positions in the cortex. So normally during brain development, the neurons migrate correctly from their origin to their final destination in the cortex. So when this normal migration takes place, grossly and in MRI findings, we can see that the cortex appears smooth and well organized. White matter and gray matter are distinctly separated, and also the ventricles have a normal shape and size with no nodules. So Moving on to the classifications of neuronal heterotopia, there are three subtypes, one being the subependymal heterotopia, which is also known as periventricular nodular heterotopia. So here, clusters of neurons are found along the walls of the lateral ventricles. These neurons fail to migrate to the cerebral cortex. In subependymal heterotopia, grossly we can see that the nodules of gray matter along the ventricle walls. And in MRI findings, it is seen that clusters of neurons appear as nodules along the walls of the lateral ventricles, and these nodules are often symmetrical and follows the ventricular contours. The next is the subcortical heterotopia, where the neurons are located in the subcortical white matter, where it's situated between the ventricles and the cortex. So here, grossly, it can be seen that ectopic gray matter within the white matter between the cortex and ventricles, and the MRI finding shows the irregularly shaped masses of gray matter located within the subcortical white matter, and these masses do not extend to the cerebral cortex. The third one is the band heterotopia, which is also known as subcortical band heterotopia or the double cortex syndrome. Here, the bands of the gray matter are located beneath the cerebral cortex within the white matter. These neurons fails to reach their proper destination in the cortical plate. So in band heterotopia, gross finding shows that bands or layers of gray matter situated beneath the cortical surface. And in MRI findings, it can be seen that the continuous or discontinuous bands of gray matter within the white matter beneath the cortex. The bands typically parallel to the contours of the overlying cortex. The causes of neural heterotopia includes the genetic mutations, first being the FLNA gene mutation that causes periventricular nodular heterotopia. And the DCX and LIS1 also causes or leads to the neuronal heterotopia, because these two genes, which is the DCX and LIS1, is very crucial for cytoskeletal dynamics and cellular motility. So when these two genes are mutated, this will lead to abnormal neuronal migration process. Second is the structural brain anomalies, where conditions like hydrocephalus impairs normal neuronal migration. And third, being the metabolic disorders, where dysregulation in folate metabolism and abnormal mitochondrial function can lead to abnormal neuronal position. The signs and symptoms or the common symptoms of neuronal heterotopia are the seizures, development delays, cognitive impairment, motor abnormalities, and behavioral issues. And the diagnosis of neuronal heterotopia involves the MRI, which is the magnetic resonance imaging, the EEG, electroencephalogram, and also genetic testing. Genetic testing is done to see to conduct if a genetic cause is suspected, as how I explained before, the gene's mutation. It can be found if there's any particular gene is mutated that causes the abnormal neuronal migration. Moving on to the treatment options for neuronal heterotopia includes anti-epileptic drugs, also known as AEDs. It's a primary treatment for seizure management. The second is special education, where there's tailored educational programs for cognitive and development support. Third being the physical and occupational therapy. Fourth is the behavioral therapy. And the last is surgery, where surgery can be considered in rare cases if seizures are refractory to medication. Moving on to the second topic, which is the agenesis of corpus callosum, also termed as ACC, is a rare congenital disorder characterized by the partial or complete absence of corpus callosum, the structure that connects the cerebral hemisphere and facilitates the communication between them. So it also classified into two subtypes, which is one, the complete agenesis of corpus callosum, and the second, partial agenesis of corpus callosum. The complete agenesis of corpus callosum is defined as the entire absence of corpus callosum. and it can cause significant neurological cognitive deficits. So, the symptoms of complete agenesis of corpus callosum are intellectual disabilities, development delays, seizures, poor motor coordination, and social interaction issues. And the second, partial agenesis of corpus callosum is defined as the corpus callosum being partially present but underdeveloped or malformed. So, the symptoms are generally milder than the complete agenesis, and the symptoms of partial agenesis of corpus callosum are mild learning disabilities, minor coordination issues, subtle social interaction challenges. So usually the corpus callosum, which is a major white matter structure, it connects the two cerebral hemispheres that allows communication between them. In a normal brain, grossly, a thick C-shaped band of white matter connects the two hemispheres. And in MRI findings, it can be seen the corpus callosum appears as a distinct curved structure spanning the midline of the brain. So normal signal intensity and continuity are observed. In complete agenesis of corpus callosum, the gross finding shows absence of the corpus callosum, and MRI finding shows no visible corpus callosum. The lateral ventricles are widely separated, and the interhemispheric fissure extends deeper into the brain. Um, the props bundles, which are aberrant white matter tracts, may be visible. In partial agenesis of corpus callosum, the gross finding shows the partial absence, usually the posterior part of corpus callosum. So the MRI finding shows the anterior portion of the corpus callosum being present, but the posterior part is missing. The remaining corpus callosum may appear thin or malformed. So this agenesis of corpus callosum is also associated with other brain malformation, which is the Dandy-Walker malformation, the Chiari malformation, and also the focal cortical dysplasia. So the Dandy-Walker malformation is a congenital brain malformation that involves the cerebellum, the fluid-filled spaces around it, and the connecting brainstem. In Dandy-Walker malformation, the space where fluid normally flows between the brain and the spinal cord is enlarged, and the cerebral vermis may be absent or underdeveloped. These can lead to a range of symptoms, including development delays, problem with coordination and balance, and increased intracranial pressure. The Chiari malformation, this condition involved the displacement of the cerebellar tonsils into the spinal canal. And this malformation can cause symptoms such as headaches, neck pain, dizziness, difficulty swallowing, and numbness, or tingling in the hands or feet. The focal cortical dysplasia is a type of developmental abnormality in the brain where the normal organization of neurons in the cerebral cortex is disrupted in certain areas. It can cause seizures that may be difficult to control with medication. And this focal cortical dysplasia can sometimes be detected on brain imaging studies such as MRI, but it may require further evaluation with specialized tests such as EEG, electroencephalogram, or intracranial monitoring to confirm diagnosis and determine the best treatment approach. So these associated conditions can complicate the MRI appearance, showing enlarged ventricles, cyst or abnormal brainstem, and cerebellar dysfunction. Um, dysfunction. Okay. So the etiology of agenesis of corpus callosum is the gene mutation where the ARX and L1CAM gene, which is crucial for the development and formation of the corpus callosum, is mutated. The second is chromosomal abnormalities. These include the numerical chromosomal abnormalities such as trisomy 8, 13, or 18, and structural chromosomal abnormalities like deletions, duplications, or translocations. The third, which is the intrauterine infection or insults, is the infections such as rubella, toxoplasmosis, or exposures to any toxins and alcohol during pregnancy can interfere with the normal development of corpus callosum. The symptoms of agenesis of corpus callosum is the seizures, the development delays, intellectual disabilities, speech and language delays, coordination and motor challenges, and social and behavioral issues. ACC can be diagnosed through prenatal ultrasound and can sometimes detect which can sometimes detect the agenesis of corpus callosum before birth. Second is the MRI, where postnatal MRI confirms the diagnosis and evaluates the extent of the condition. And third is the genetic testing, where it identified the potential genetic causes or associated syndromes. The treatment options for agenesis of corpus callosum is the anti-epileptic drugs to manage the seizures if it presents, development therapy, which includes physical, occupational, and speech therapy to support development, special education services, behavioral therapy, and supportive care. In conclusion, both neuronal heterotopia and agenesis of corpus callosum are complex disorders that significantly impact brain function and development. Early diagnosis and a multidisciplinary approach to treatment are crucial in managing this condition effectively and in a positive way. Here are the references and sources used in preparing this presentation. That's all from me. Thank you for your attention.
Good afternoon. May I ask you about neural tube defect?
Right, sure. Have a seat. So for neural tube defects, they are congenital malformations of the central nervous system, spine and cranium. So for neural tube defects are caused by incomplete closure of the neural tube during neurulation, which takes place during between the third week and the fourth week. So after conception. So for cranial defects, it is caused by incomplete closure of anterior neural pores, where the cranial cleft formation will have occur with involvement of the skull and brain. Next is for the spinal defects. What happens is that incomplete closure of the posterior neural pores, which results in bone defects of the vertebral arches, mostly at the lower lumbar or sacral region, where it could possibly cause herniation of the spinal neural tissues and meninges. For neural tube defects, it can be classified according to the affected structure and degree to which the defect is covered by tissue. For example, open neural tube defect, meninges or neural tissue are uncovered and therefore freely exposed to the surrounding. For example, amniotic fluid. Next is for the closed neural tube defect is due to defect which is covering the skin and or connective tissue. First, I'll be explaining about the anencephaly. So anencephaly is a malformation of the anterior end of the neural tube, where at the rostral neural pores remains open, which leads to absence of forebrain and open cranial wall. Okay, as you can see in this picture, this is the normal baby, where you can see the forebrain, midbrain, and hindbrain. And for the baby that's suffering from anencephaly, you can see there's absence of forebrain, open cranial wall, and this causes the alpha fetoprotein levels to increase, which leads to polyhydramnios. Okay, so this is the gross picture. As you can see, there's an open cranial wall for this baby here, right? Start off with the clinical significance. As you know that I have mentioned earlier about polyhydramnios, where an excess amount of amniotic fluid during gestation as a result of either increased production or decreased reabsorption. This can be due to the fetal gastrointestinal abnormalities, for example, esophageal or duodenal atresia, where impaired swallowing, for example, anencephaly, or associated with maternal factors such as diabetes mellitus, infection, or rhesus incompatibility. Next is for this kind of case, what happens is that the patient will be having difficulties in thinking, seeing, hearing, touch, and movement due to cerebrum malformation. Next is, as I showed earlier, there will be missing of bones at the front and sides of the head. and there will be no bones on the back of the head, which causes the cranial wall, opening of the cranial wall. To move on, there will be large areas of brain missing. For example, as I showed earlier, there will be missing of forebrain. So for the next important thing that you should know is spina bifida occulta. So it is the least serious form of spina bifida, where it's only a vertebral bone defect without herniation that occurs, but there will be no abnormality of the spinal cord, meninges and overlying skin remains intact. So for the site of bone defect is marked by a small dimple or a hairy pigment mole in the overlying skin, also known as tuft of hair. As you can see in this picture, there's presence of tuft of hair at the overlying skin. For the clinical features of spina bifida occulta, it mostly occurs at the lower lumbar or sacral region, often asymptomatic, but maybe we can find an incidental finding in imaging. So for the possible symptoms at the level of the vertebral defect is, as I mentioned earlier, patch of hair, collection of fat, lumbar skin dimple. Next, we can see the patient where bladder problems, for example, constipation or incontinence, and back pain. Next is muscle weakness at the legs can be present in this patient as well. All by right. So, but don't forget to know about Anencephaly and Meningocoele. For that, you can refer to Dr. Sophie for the knowledge that she will share with you. That's it. Thank you. Hi, Dr. Sophie. Hi, Dr. Nabi. Right on time. So, Baihaqi, you can ask Dr. Sophie about Anencephaly and Meningocoele.
Okay, doctor.
Okay, Dr. Jason.
Yes, ma'am. Can I know about the meningocoele and cephalocephale?
What do you want to know? Everything.
Everything.
You're supposed to know this. Okay. So this is very important. So the first one, meningocoele, is actually like the least common type of spina bifida, where there's like a sac protruding from the spinal column. Do you know what the sac contains? You don't know anything, you know. So the sac includes spinal fluid, but it doesn't contain like neural tissue. It may be covered with skin or with meninges. So the sac is often visible from the outside of the back. You know how it occurs? Obviously no, you don't know. So the primary bone defects that are caused by abnormal axial mesoderm development and lead to secondary CNS abnormalities. So the clinical features would be like there's like no neurological deficits, but there's like sac-like protrusion from the meninges and CSF from the back, bladder incontinence, back pain, Syringomyelia, Chiari, malformation, clubfoot, gait disturbance.
Doctor, can you explain me this picture?
Oh yeah, so this part is the meningocoele containing spinal fluid. So this one is meningocoele.
Understood.
Alright. So is that all?
Yeah. How about encephalocephale?
Encephalocephale. So basically it's like herniation of malformed CNS tissue. So it's pretty rare. It's a rare congenital birth defect of the neural tube. So it is a diverticulum, which is a herniation of the malformed CNS tissue extending to defects in the cranium. So defect in the cranium could be an abnormal opening in the skull that promotes sac-like protrusion of the brain and its membrane, like back here. And then this could happen when the neural tube fails to close completely during pregnancy, which results in opening anywhere, often in the back of the head, occipital region, and posterior fossa. So other possible openings include along center of the skull, from nose to the back of the neck, top of head, or between forehead and the nose. And the symptoms could like vary from one individual to another depending on different factors like size, location, and the amount of brain tissue protruding from skull. So the posterior encephalocele are more often associated with neurological problems. So the signs and symptoms are build-up of too much fluid in the brain, complete loss of strength in the arms and legs, unusually small head, uncoordinated use of muscle for movement like ataxia, developmental delay, intellectual disability, vision problems, and delayed growth and seizures. So,
How about this picture?
okay, this one is the encephalocele. So you can see the mass underlying the posterior neck. This one, alright.
How about myelomeningocele?
I'm a bit busy, but can you ask Dr. Nabi? You can have a
Thank you.
Bye bye.
I forgot to ask Dr. Nabi. Let me ask him first. Tomorrow, right? Let's go.
The next day,
May I come in, doctor?
Yes, you may come in.
Hi, doctor.
Hello, Baihaqi. Please have a seat.
Thank you, doctor. I want to ask regarding the myelomeningocele, doctor.
Okay, sure. But then before that, do you have any idea about myelomeningocele?
I think it's the form of spina bifida cystica and the most common part of spina bifida.
Yes, you are right, Baihaqi. So, myelomeningocele is an extension of CNS tissue through a defect in the vertebral column, and it mostly occurs at the lumbosacral region, and it arises due to the failed closure of caudal end of the neural tube, which results in an open lesion. So, the etiology of myelomeningocele can be multifactorial, such as genetic, environmental factors. And those who are suffering from myelomeningocele, the clinical features are derived from abnormal spinal cord segments and often accompanied by infections. For example, the patients who are suffering from myelomeningocele can present to the clinic with symptoms of motor and sensory deficits in the lower extremities, as well as bowel and bladder control problems which can cause hydronephrosis, and also muscular imbalance which results in joint contractures and developmental problems such as hip dislocation and spinal deformities. So Baihaqi, I also have some gross pictures of myelomeningocele. So here you can see that there's a cyst-like structure just above around the lumbar sacral region, and this cyst-like structure contains spinal cord parenchyma as well as the meninges. And there's also another picture that I've got to show to you, and this is like the cyst-like structure as well at the lumbar sacral region, and here you can see the spinal cord remnants as well as the skin is intact. So Baihaqi, do you know how to diagnose neural tube defects?
I'm not so sure, but I think it's alpha-fetoprotein serum,
Yes.
and also the fetal ultrasonography, right?
Yes, absolutely, Baihaqi, you're right. So for the diagnosis of neural tube defects, you can, as you mentioned before, we can use the alpha-fetoprotein level as well as the fetal ultrasonography. So the lab screening test can be done through blood tests, amniocentesis, or both, which are combined with fetal ultrasonography. As for the alpha-fetoprotein level, blood samples are taken in the second trimester of the pregnancy, which are usually around week 14 to week 20. And the alpha-fetoprotein level can be elevated in amniotic fluid, which indicates open neural tube defects, and mostly it is peak around 13 to 15 weeks of pregnancy, which allow for diagnosis. The maternal serum AFP is also confirmed with amniocentesis, amniotic fluid assay, and also presence of a nerve-specific enzyme, which is acetylcholinesterase. But then, however, there's some disadvantages of using alpha-fetoprotein level. Patient like children who are suffering from encephalocele or skin-covered myelocele cannot be detected through the alpha-fetoprotein level. And amniocentesis is also suggested for subsequent pregnancies in order to monitor the AFP level among the pregnant women. As for the fetal ultrasonography, it is done at approximately 18 weeks of gestation or pregnancy. And as you know, combination of serum AFP and ultrasonography screening able to detect around 90% of the neural tube defects. And myelomeningiocephaly can be detected during the scanning of fetal head for subtle changes in cranial and cerebellar configurations. So Baihaqi, do you have any more doubts to ask?
I think the all is clear.
Okay, Baihaqi, don't forget all the information that I mentioned to you, okay?
Why?
Because it is really important from exam point of view, and I can ask any question I want from neural tube defect. So neural tube defect is an important topic from an exam point of view. So please don't forget, okay?
I will share to my friend.
Okay, sure, Baihaqi.
Hi, hello everyone. Okay, let's continue with the posterior fossa anomalies. There are two types of it, which is the first one is the Chiari malformation and the second one is Dandy Walker malformation. Okay, for the Chiari malformation, there are several types, but I will focus into the two, which is the type 1 and also the type 2. Okay, so what is the Chiari malformation? It's actually a distinct set of the malformation that primarily affect the brainstem and also the cerebellum, which it is often show dramatic changes in size and also shape. For the Chiari type 1, it is more than 5 mm descent of the caudal tip of the cerebellar tonsils past the foramen magnum. For the Chiari type 2, it almost similar, but it is with the Spina Bifida. Okay, next, we focus first with the Arnold Chiari malformation. We call it as the type 2 Chiari malformation. Okay, this condition has skull, dural, brain, spinal cord manifestation, including the downward displacement of the medulla, fourth ventricle, and also the cerebellum into the cervical spinal canal, as well as the elongation of the pons and also fourth ventricle. This is probably due to the small posterior fossa. And other associated changes may include the caudal displacement of the medulla, malformation of the tectum, aqueduct stenosis, and also the hydromyelia. Okay, so let's continue first with the Arnold Chiari malformation, right? Okay, so we have picture here is this is the normal one. Okay, so the normal one is the cerebellum is dead in case, but for the Chiari malformation, this is the foramen magnum. Then the cerebellum is extended downward below the foramen magnum. Okay. And then we have the radiograph picture. So this is the normal one. This is the normal one. Yellow one is the foramen magnum. And this is the Arnold Chiari malformation. Okay, this is the Arnold Chiari malformation. For the pathophysiology, what is happened is that the cerebellar tonsils herniate into the foramen magnum. This will cause compression of the ventricle and those block the flow of the CSF. And it also have the herniation of the cerebral vermis and associated with the myelomeningiocephaly. That is one of the anomalies associated with the type 2 Chiari malformation. But other than that, there is also the Agenesis of the Corpus Callosum and also the Syringomyelia. For the symptom, it can cause changes in breathing pattern, trouble swallowing, and also weakness in the arms. So let's move on to the Chiari type 1 malformation. It is a less severe disorder in which the low-lying cerebellar tonsils extend down into the vertebral canal. It can be silent or maybe symptomatic because of its disruption to the CSF flow and also cause the medullary compression. But the Chiari type 1 patient have increased risk of the concussion and also post-concussion syndrome. Okay, so here you can see the arrow is the debating edema in the central region. And also here you can see this is the level of foramen magnum, right? So this is the cerebral tonsils. The cerebral tonsils descend below the level of the foramen magnum. So this is the Chiari type 1 malformation. Okay, so for the symptom for Chiari type 1 is bad headache, neck pain, unsteady walk, and also speech changes, dizziness, and also numbness. So let's continue with the Dandy Walker malformation. It is named after two neurosurgeons who described it in 90s, which is the Walter Dandy and also the Arthur Walker. Okay, so what is actually Dandy Walker malformation? It is characterized by agenesis or also hypoplasia of the cerebral vermis, cystic dilation of the fourth ventricle, and also the enlargement of the posterior fossa. The cerebral vermis is absent or present only in rudimentary form, its anterior portion. In its place is a large midline cyst that is lined by epiderma and is contiguous with leptomeninges on its outer surface. This cyst represents the expanded roofless fourth ventricle in the absence of a normally formed vermis. Dandy Walker malformation may be associated with the atresia of the foramen of Magendie and possibly the foramen of Lashkar. Okay, as you can see here is the radiograph of the Dandy Walker malformation. This is large cerebrospinal fluid in the posterior fossa, and also you can see here thin occipital bone. For the pathophysiology, Dandy Walker malformation consists of malformation of the roof of the fourth ventricle and of the cerebellum. The cerebellum is poorly developed and is displaced upward and laterally. The enlarged fourth ventricle balloons out backward. The fourth ventricle is grossly misshapen because it is a membrane-wrapped cyst that extends into the foramen magnum. The membrane-wrapped cyst may leave and displace the posterior portion of the brain, as well as cause an internal obstruction of normal CSF flow with resultant hydrocephalus. For the clinical presentation, they can present with enlarged posterior fossa, cyst formation is the posterior fossa, varying degrees of cerebral and vermin hypoplasia, absence of foramina of Lashkar and Magendie, and also hypoplastic cerebral hemisphere, wings anterolaterally. Okay, that's all from me. Continue with the next.
Syringomyelia. Syringomyelia is development of a fluid-filled cyst known as cavity or syrinx within the spinal cord. This cyst can expand and elongate over time, compressing and damaging the spinal cord from the inside out. Now let's have a look at the causes of syringomyelia. First of all, Chiari malformation, which is the most common cause, where the cerebellar tonsils herniate into foramen magnum, obstructing the CSF flow. Next is spinal cord trauma, where injuries can lead to scar tissue formation, disrupting CSF flow and leading to syrinx formation, and spinal cord tumors, which can block CSF flow and contribute to the development of syrinx. Lastly, arachnoiditis, which is inflammation of arachnoid membrane and also disrupt the normal CSF circulation and contributing to syringomyelia. The symptoms are weakness and atrophy in the hands and arms, loss of reflexes, chronic pain, particularly in the neck, shoulders and arms, and stiffness in the back, shoulders, arms and legs. Destruction of the spinothalamic tract also leads to loss of pain and temperature sensation in a cape-like distribution over the back and arms. If the syringomyelia left untreated, it may also lead to paralysis, chronic pain due to spinal cord damage, and also motor difficulties. Hydromyelia. Hydromyelia is a condition characterized by the dilation of the central canal of the spinal cord, leading to an abnormal widening filled with CSF. The causes are, first of all, congenital conditions often associated with congenital anomalies such as Chiari malformation or Spina bifida. Next is infections. Meningitis or other infections that impact the spinal cord can also lead to hydromyelia. Trauma. Spinal cord injuries may contribute to the development of hydromyelia, and lastly, tumor which obstruct the CSF flow will lead to central canal dilation. The symptoms are similar to Syringomyelia but often less severe, which may include weakness, sensory disturbances, and pain depending on the extent and location of the central canal dilation. Diagnostic method for both Syringomyelia and also hydromyelia is MRI. As we all know, Syringomyelia is a condition where a fluid-filled cyst forms inside the spinal cord. So in this case, MRI helps to show the pictures of the spinal cord showing the strings clearly. When it comes to hydromyelia, it is a central canal of the spinal cord is abnormally enlarged with fluid. So in this case, MRI helps to show the enlarged central canal. The treatment for Syringomyelia and hydromyelia is same. First of all, surgical intervention. It is the primary treatment, which may involve decompression of Chiari malformation, removal of obstruction or drainage of the strings. In some cases, shunt placement may be necessary to drain the strings.
Okay, that's all for my story. But don't believe the magic. What's the magic one? The enriching life transforming future.
Thank you for watching.
Okay, wait. Again.
Mistakes, all we hear is sad songs, but heartbreaks, and no